functional component of the spinal cord today, and then go back over the spinal nerves that we covered with muscle, and talk about their organization as far as what plexi they come off of and the groupings of the spinal nerve. You're familiar with the terms, all right, but we're going to look at them in lab today and associate them more visually with the muscle compartments and muscles that they're found with. And then we're going to, back to lecture, look at the embryological development. How do we get to the spinal cord and brain? And that leads us into the formation of the ventricles. And we'll look at a couple of the sinuses, how the cerebrospinal fluid is removed from the brain, because in our next unit we'll look at the venous drainage, and that will include the rest of the sinuses. So just an introduction to that today. So we looked at the cross-section in lab, as I indicated, but now I want to go over some of those same meningeal structures, as well as some of the components on a longitudinal view. So our spinal cord begins at the foramen magnum. And it's not just an arbitrary landmark. There are actual internal differences in the appearance of the brainstem in cross-section versus the appearance of the spinal cord. So we find the gray matter, that H pattern of gray matter completely changes once we look at the brainstem. And we'll be doing that after spring break. The spinal cord ends at the level of L1, L2 vertebra. And so the spinal cord just doesn't grow as rapidly in the infant as it does, as the vertebral column does. So there's always some vertebral foraminal space in the infant, but that amount increases. So it extends a little bit farther in the infant lower vertebra, but we still have some free space. There are enlargements, so my diameter of the vertebra here is not proportional. But when we get to the lower cervical and a couple of the upper lumbar spinal nerves, we see this in the nerves. We have C5, C6, C7, C8, and C1 go into the upper extremity. And with those additional cell bodies in the anterior great horn and the additional sensory information coming back from the upper extremity, this creates a dilation, if you will, an enlargement known as the cervical enlargement. It's not like a big ganglion there, it's not a big knot, it's a slight enlargement. And then we see another one, a little more subtle, down in the lower area, known as the lumbar enlargement. And this is because our lumbar nerves and our sacral nerves, so L4, L5, S1 through 5 nerves are going into the lower extremity. And so the motor cell bodies of the motor neurons and that additional sensory input creates that. Okay. This pointed area, we redraw it in a different color, looks a bit like the cone component of an ice cream cone. And so this is identified as the conus medullaris. And so that's the tapered portion of the spinal cord. Now, as we'll see today in a few minutes, when we look at spinal nerves, our sacrum actually has the sacral canal. We learned about that. And there are anterior and posterior sacral foramina where the spinal nerves exit, and the sacral hiatus at the very end where our coccygeal nerves are coming out. So we have pairs of spinal nerves, 31, that exit or enter, because we have both motor and sensory components, but they pass through the intervertebral foramina. Remember those bony openings created by the inferior and superior intervertebral notches. So at those locations, pairs of spinal nerves pass through. And at the cervical level, they're going to extend almost horizontally to the locations, and I'm not sure that I'm drawing exactly 31 pair here. But as we move inferiorly in the spinal cord, their openings end up becoming lower than the level of the spinal cord that they pass through. So we start to see the spinal nerves having to angle downward to find their appropriate intervertebral foramen. That becomes more and more pronounced until, of course, the ones that are coming off the sacral portion of the spinal cord have to travel quite far to find their exit. And we have only spinal nerves in this lower portion. This bundle of spinal nerves reminded somebody of a horse's tail. And so this is identified as the cauda equina, or horse's tail. And this level is the level I mentioned in lab for my lab sections where penetration of the dural sac would occur for spinal anesthesia or for withdrawing some bone, some CSF. Yes.
And is that the same thing as the floor?
Not yet. We haven't gotten to that. That's a meningeal structure. Okay. So between L3 and L4 is where a spinal tap would occur, because there is no spinal cord at that point, just spinal nerves. Spinal tap is spinal anesthesia. So we put the meningeal structures on the, we looked at those in lab on the diagram. So I want to add them to this area here. And the most intimately associated meninges, the one that has vessels, blood vessels within it, and is on the surface of spinal cord and brain, is with what layer? Remember what the innermost meningeal structure is? Pia mater. So I'm going to draw that in red. And remember, between each intervertebral nerve, pia mater was pulled out to the side. And we'll assume so, I didn't go all the way down. And that attached to the arachnoid and dura mater. Anybody remember what that was called? Referring to the tooth-like appearance?
Denticulate ligament.
Denticulate ligament. All right, so pia mater, and then formed by the pia mater. Let me write that in red so you associate it with it. The denticulate ligaments are formed of pia mater, and then when the pia mater reaches the conus medullaris and tapers to a point, it continues to extend as a single filament of connective tissue. It's mixed up with the nerves, but you can find it by going right to the tip of the conus medullaris. And this is anchored to, let me draw a little bit longer, it goes down to the coccyx. And this is identified as phylum terminale. So recognize that phylum terminale and denticulate ligaments are both formed of the pia mater. Between the pia mater and the arachnoid mater, we have our subarachnoid space. I'm drawing the arachnoid mater now. The arachnoid mater and dura mater are going to stop at S2 level. Remember, it's called the arachnoid matter because it has these spidery filaments. Between the two, we have subarachnoid space between the pia mater. And this contains CSF. The cerebro. Spinal fluid. And we'll talk about the formation of that when we get to the ventricles. Okay, then the outermost, tougher layer, inherent to the arachnoid matter, is the dura mater. That also stops at S2. So when spinal fluid is drawn or anesthesia is given, it's in this space right here, in the dural sac right here. So both the dura and the arachnoid matter are penetrated, and then you're in the cerebrospinal fluid because the pia mater is only this thin strand. So when we're looking at the long green flat model that has a three-dimensional spinal cord on it, the one that I showed you for quadratus lumborum when we were doing the muscles, find the tapered region, which is conus medullaris. Look at the very center of it, and you'll see what looks like a nerve continuing on down, and that would be the pia mater. Okay, any questions on the spinal cord? I'm going to move that over to the side, and I want to talk about spinal nerves now. I'm going to pull the screen down for just a moment. Section of the spinal cord and chest through the ribs to show the basic pattern without changes. So we're going to talk about the plexuses. There's a region of the spinal cord at which plexuses don't form, so I want to show you the norm, even though it's the minority, before changes occur, and then we'll look at the plexuses. So this should be familiar to you from our spinal cord model in lab, section of the spinal cord that's within the cervical vertebra. And so this would be the vertebral body. So this is ventral. Spinous process is dorsal, so that helps you look at your arrangement of the spinal cord is rather small in this location. So this would be the epidural space outside the dura mater with adipose tissue and blood vessels. There's our dorsal root ganglion. The spinal nerve is located right about the opening of the intervertebral foramen. And that spinal nerve is what we call it before it divides or forms from the ventral rami and dorsal rami. So then we have the dorsal ramus right here. Notice how it only goes to the back. It's going to innervate these deep muscles of the back between the spinous processes and transverse processes, including the erectus spinae, and then it provides sensory innervation from the skin of the back for about 4 inches just lateral to the spinous processes. That's why it's such a small, short branch. None of the dorsal rami form plexuses. So again, when we were talking about innervation of our deep muscles, we didn't name these dorsal rami. We just said splenius capitis in the head was innervated, in the neck was innervated by cervical dorsal rami. Longissimus, if it's in the lumbar region, would be innervated by lumbar dorsal rami, and so on. So when we look at our intercostal muscles, this would be external intercostal, internal intercostal, and there's another one not shown that's the transversus thoracis, like our transversus abdominis. here's the ventral rami passing out through those and providing, here would be sensory branches, bringing in sensory information of pain, touch, and temperature from the skin, and these are the motor branches. So that doesn't change, all right? That's our unmodified pattern of dorsal rami and ventral rami. And if we think of that pattern, we see a similarity, a segmentation, if you will, of the sensory areas of the skin. We don't see this with motor innervation. So for instance, the radial nerve that innervates posterior arm and posterior forearm is a combination of neurons from C5, C6, C7, C8, and a little bit from T1 to the muscles that go to the little, extend the little finger. The axillary nerve that does deltoid and teres minor is mostly C5 and a little bit of C6, but not all of C5. That, as we know, goes to the ulnar and goes to the median and the radial nerve. However, for sensory innervation, we have this segmentation that's known as dermatomes. So each level is sensory innervation is provided by a single spinal nerve. And this before the broad use of MRIs to look for neurological damage in spinal cord or peripheral structures was what neurologists use to determine, help to determine the level of damage to either spinal nerves or to the spinal cord. And so there's a few of these dermatomes that I want you to learn. All right, you can shade them in or write them down. You'll notice that over the shoulder area is C5. All right, and that is recognizable because our axillary nerve is primarily C5. So someone who, let's say, is riding their motorcycle and leaves the road and they're hit a tree and their neck is hyperextended because they hit the tree at this area, it's going to tear the roots of C5 from the spinal cord. Or a baby who is born bottom first, and the physician stretches out the neck trying to pull the head out, that can tear roots of the C5 and C6 dermatomes, nerves. So not only would they have muscle damage, but they would have an area of anesthesia or loss of pain and temperature sensation over the shoulder. Okay. Then if we follow that down, you can see that the thumb and lateral aspect of the hand is done by C6. So recognize that the thumb is C6 and the little finger is C8. Okay, again, this is sensory innervation. If we look at the chest level, the nipple level is T4. So if someone says they're in a motorcycle accident, when I was observing when I was in nursing school, my very last weekend was to observe in the emergency room. And I was in the examining room, and they were physicians who were checking out a young man in his late 20s who had been at work and had gone out to get some beers for the guys for dinner break and forgot to put his kickstand up, and the bike flipped when he was going around a corner. And so I was in the examining room as they're poking him, and he's like gradually getting the realization that he can't feel below certain areas. So if you don't have any feeling below the T4 level, below the nipple level, they know that the spinal cord has been damaged at least as high as the T4 level. Okay. Hint being a paraplegic. I went back to see him in the neuro-intensive care a couple days later, and he was still hoping that he would get some feeling back and some movement back. He was moved to a rehab shortly after that, and I lost contact with him, so I'm not sure if he did or not. But a lot of damage occurs, as you see it on football fields, with swelling. So a lot of medical research has led to decrease in neurological damages by providing medications that kind of act like diuretics, remove the fluids, and decrease the swelling, so the loss of sensory and motor function is not permanent. And I also want you to know that the umbilicus is at T10, the belly button level. It's going to be at T10. They're not showing his belly button, but that's where it would be. And then the lower extremities, if you put your hands out like this, all of the diagrams, all of the dermatomes are horizontal, all right, and then they become vertical with the lower limbs, but again, if you were to do the splits, they would end up being horizontal with that. But I just want you to know that S3, S4 is the central gluteal area, all right, so right around where we would find piriformis and obturator internus is S3, S4, and we'll leave it at that. Okay, so C5 for shoulder, C6 for thumb, C8 for little finger, T4 for nipple area, T10 for belly button, umbilicus, and S3, S4 for the central gluteal region around the anal area. All right, so going through, we'll look at PowerPoints for the lecture material on the spinal nerves. We have the cross-section that I showed you was thoracic spinal nerves. We have 31 pairs, and we have 8 cervical spinal nerves. Before I come back to this diagram, let me just draw something on the board over on your far right. We have 7 cervical vertebrae, but we have 8 cervical spinal nerves. So here is the skull, and here is our first cervical vertebra, second, a bigger body than it actually has, and so on. Our first cervical spinal nerve is going to come out between the skull and the first cervical vertebra, C1. The second comes out above the second cervical vertebra, and so on, until we get to C7, our 7th cervical vertebra, and our 7th cervical nerve comes out above C7, and then we get our first thoracic vertebra, and C8 is going to come out below the 7th cervical and above the first thoracic vertebra. After that, the spinal nerves are numbered for the vertebra that they come out below. So this is coming out below T1. This is the first thoracic spinal nerve. All right, this is coming out below T2. That would be the second thoracic spinal nerve. So until we get to C8, all of the cervical spinal nerves come out above the vertebra for which they're numbered. 8 comes out below C7. Then after that, so the first lumbar vertebra would come out between L1 and L2. So that's how we organize the spinal nerves. And then we have plexuses. So we're going to have a cervical plexus. We have a brachial plexus, which includes a couple of thoracic spinal nerves. No intercostal plexus. All the intercostal nerves are just ventral rami. Let me say no thoracic plexus. The intercostal nerves are formed by ventral rami. Sorry, keeping that from people that are on the far side of the room. And then we have a lumbar plexus. And a sacral plexus. There's one page in your lab manual that calls the lumbar plexus the femoral plexus, and that's an error. Okay, there are no femoral plexuses. So we have 4 plexi, and we're going to go over the nerves that we find within them. I think there's only one nerve that I haven't already mentioned to you, and that's the pudendal nerve. All right, but everything else we've already talked about. It's because the pudendal nerve innervates muscles that we didn't cover when we did the muscle section. Every other nerve that I'll talk about we've already mentioned. All right, so what do we mean by a plexus? Probably the brachial plexus is the easiest to look at when we talk about a plexus. So in blue over there, and you don't have to have this memorized, If you take 122 next spring, you'll go over it. You'll learn what muscles are damaged if you cut C4, C5, what muscles are weakened, or if you cut the middle trunk, what muscles are weakened. But I just want you to understand what we mean by a plexus. So C4, C5, C6, C7, C8, C1 are the roots, all right? And those are formed by the ventral rami. So they're the roots of the plexus, but they're formed by the ventral rami of the spinal nerves at each of these levels. And then imagine them to be bundles of yarn. And we take bundles of C4 and C5, almost both of the root bundles, and bring them together to form the upper trunk, along with C6. And then we split part of that off to form the posterior cord, and we just kind of keep interweaving neurons from different levels. So if we were to cut C5, notice that this nerve, the long thoracic nerve, you don't have to know it, but it innervates latissimus dorsi. So if you were to cut C5, would you still be able to move latissimus dorsi? Notice the long thoracic nerve also gets C6, C7, and well, C6 and C7, so you'd still have some muscles innervated, but it would be weak. The dorsal scapular, which goes to supraspinatus and to the rhomboids, would be completely lost because it's all C5, all right? The median nerve has C5, but it also has all the others. And so while muscles might be weakened, we're not going to lose the entire function of all the nerves innervated by the median nerve. So we grab neurons from different roots and blend them together to make the different terminal nerves. That's what we mean by a plexus.
So plexus is just branches going into muscle?
I don't want to say branches as it's components of variable numbers of spinal nerves blended together. Okay? And so the brachial plexus is the easiest to follow of those blendings. And we'll talk about that a little bit more in a few minutes when we get to the brachial plexus. But the same thing happens, we have a cervical plexus. Okay? So here it's branches of C1, 2, 3, 4, a little bit of 5, and that are going to the cervical plexus. Your lab manual has just one nerve that you need to know from the cervical plexus, and that's the phrenic nerve. So this one right here is taking branches of C3, C4, and C5. Go ahead and write that down. You don't need to know this contributions to all the nerves. This one has a cute little saying, C3, C4, keep C3, C4, and 5 keep the diaphragm alive. So this is phrenic nerve, going to the diaphragm. Right. And then we talked about ansa cervicalis, going to the sternohyoid, so I want you to add that one to your lab list. It's in your online lecture notes. Remember I said it formed a loop? So this is the loop that I'm outlining right here. There are quite a few infrahyoid muscles, all the ones that you see here. The only one that you needed to know, however, was sternohyoid. Going from the sternum to the hyoid, depressing the hyoid bone. And so here's a branch of ansa cervicalis. So it's not going to be just one ventral root, all right? It's several, it's C1, 2, and 3. That part you don't have to know, just the phrenic nerve, 3, 4, and 5. But again, for lecture, recognize the muscle that they innervate and recognize that it comes from the cervical plexus. Okay? Or in lab, another one of those 4 or 5 additional type questions that we ask, I might tag the cervical plexus or the brachial plexus and say, name one nerve that originates from this plexus. So in the case of the cervical plexus, you would have 2 choices. All right, there's several other ones. If you know them, you would get credit for them, but the ones you need to know for lecture are phrenic nerve and ansa cervicalis. All right, so brachial plexus, by the time we follow the brachial plexus into the upper extremity, it's formed 3 cords. These are listed in your lecture, in your lab material, as well as in your lecture notes. And so we're here in the axillary area. The green cord is known as the posterior cord. And then we have a lateral cord and a medial cord. There are 2 nerves coming off the posterior cord that you need to know. Each lateral and medial cord forms a major nerve, and then notice the M here. That forms the median nerve. So I'm going to diagram that pattern. Let's get a different color here. On the board while I leave this on the screen. I'll draw the posterior cord first just because it's easier to draw it in the back rather than to fill it in. So the posterior cord, the nerves of the posterior cord that you need to know are the axillary nerve. And the axillary nerve, what we went over in the muscle lecture, is going to innervate deltoid and teres minor. And then the rest, as soon as the axillary nerve branches off, we have the radial nerve. And that does posterior arm and posterior forearm. The triceps brachii, extensor, all of our extensors in the forearm. Axillary nerve is going to do deltoid, teres minor. Okay. And then we have a lateral cord. And the lateral cord continues laterally as well as gives off a medial branch. We have a medial cord, which continues medially as well as gives off a medial branch. What's the nerve that runs down the lateral aspect of the forearm? Is motor to the arm, anterior arm becomes sensory to the lateral forearm. Very long one, musculocutaneous. All right, so this is lateral cord and musculocutaneous nerve. Which is motor, anterior arm, and sensory to lateral forearm, as well as anterior arm. This medial branch is the ulnar nerve. And it innervated 1.5 muscles in the anterior forearm. So it's going to innervate flexor carpi ulnaris, that's the one muscle in the anterior forearm, and the half muscle is 2 tendons of flexor digitorum profundus. So the little finger and fourth finger, the most medial tendons of flexor digitorum profundus. So the fourth and fifth digits. The rest of the muscles innervated by the ulnar nerve are in the hand. And I listed some of those in your lab manual, our online lecture notes. But those are muscles that move the thumb. And the muscles of the muscles innervated by the ulnar nerve are finger muscles, intrinsic hand muscles. All right. By intrinsic, I mean the muscles are actually in the hand itself. With one exception, they do not move the thumb. is what you hit when you talk about I hit my funny bone. And you hit your elbow against something and it tingles. It's really the ulnar nerve where it passes around the medial epicondyle. You can feel that tingle all the way down to your little finger. So the major, a lot of the muscles, what the muscles do in the hand are synergistic to muscles of the anterior forearm. They do the same thing. So if you were to break your elbow falling on it, and they ask you to flex your wrist, that's not going to test for the ulnar nerve. Or they ask you to flex your fingers, that's not going to test just primarily for the ulnar nerve. So the best test is to ask you to grasp a piece of paper. Can I borrow your piece of paper? So asking somebody to do this, you can only abduct your fingers and abduct your fingers with the ulnar nerve. So if your ulnar nerve is damaged, you might be able to flex them, but you wouldn't be able to do that. Okay, so that's why I put their abductor and adductor, but the best test is to abduct the fingers, and only the ulnar nerve can do that. All right, the muscle, the nerve that is formed by the branch where these two come together, right here is the median nerve. So that's going to do the anterior compartment of the forearm and the thumb. However, median nerve is the primary nerve that is sensory to the hand. The radial nerve is also sensory to the back of the hand, but for the fifth finger, the median nerve is sensory to the hand, and it actually wraps around to do about an inch on the back of your fingers. So if you're getting your fingernails pulled, that's median nerve, okay? Because it's just below that where you have radial nerve. All right, the muscles that are innervated you're already familiar with. And the radial nerve, we put up there already, posterior compartment. And then we get to the intercostal nerves, and I don't have a picture of that because those are the nerves that travel between the ribs, like I showed you on that first image. There is no plexus, so the intercostal nerves travel between the ribs and innervate the intercostal muscles, okay, as well as the skin of that area. And that brings us to the lumbar plexus and the sacral plexus. And we don't worry about the components, the cords and divisions and stuff of the plexi. So just the nerves that are components of those plexi. So in the lumbar plexus, we did iliohypogastric and ilioinguinal together, and those do the anterior compartment muscles, anterior wall, so our obliques and our rectus abdominis. If we were doing the perineal area, which we do at the end of this semester, we don't even cover the muscles for that, but they do innervate. Like the cremaster muscle that wraps around the spermatic cord will innervate that. Femoral nerve is the major nerve that forms from the femoral, from the lumbar plexus. It passes into the anterior thigh. It's kind of the equivalent of our musculocutaneous, which did anterior arm, and then became medial to the lateral forearm. Femoral nerve does motor and sensory to the anterior thigh, and then on the inside of the knee, it becomes only sensory. And it's sensory to the inside of the leg, which is the equivalent, it's the big toe, so even though it's the medial leg, it's the equivalent to along our thumb, so it's still equivalent. And so that portion that is medial to the leg only is called the saphenous or saphenous nerve. This is not in your lab manual, all right? So it's an addition to the material there. You don't have to identify it in lab, but it's not one of the structures that are listed. Pudendal nerve. When we get to lab, I'll show you the passageway. Pudendal actually, let me take this one here. Pudendal nerve belongs in the next plexus. So I'm going to take that one out here. It should be in our next plexus. obturator nerve, that's what you would think. Obturator nerve passes through the obturator foramen, and it's the nerve, as we discussed already, to the adductor or medial thigh area. So these go over the top of the pubic bone. They're in, except for the obturator nerve. So they're in the anterior thigh and medial thigh. What you will see in lab is a section of the lumbar plexus known as the lumbosacral trunk. This actually is L4 and 5. It's not part of the femoral plexus. It's L4 and 5 coming together, and it goes down into the pelvis and joins the sacral plexus. All right, so I'll point that out to you in lab, because even though it has it's lumbar nerves, it actually becomes part of the sacral plexus, and that's the lumbosacral trunk. So here's the lumbar plexus. Here's iliohypogastric and ilioinguinal wrapping around with the anterior abdominal muscles. Here's our major nerve, the femoral nerve, and here's obturator nerve. Okay, coming along this side right here. So it looks like it's coming off of the sacral plexus, but it's actually wrapping around the pelvic rim. And right here is the L4, L5 lumbosacral trunk. Yes?
And so which plexus is this?
Lumbar. Sacral plexus is posterior compartment and posterior thigh and leg. So the next diagram here is sacral plexus. And I want to add dental nerve here. So the sciatic nerve, if you recall from lab, passes out the greater sciatic notch, and we can see it just inferior to the piriformis. Passing out the greater sciatic notch with the sciatic nerve is going to be the pudendal nerve. And it passes over the lesser sciatic notch and heads back to the pubic triangle. Because pudendal nerve innervates muscles like your anal sphincter and your urethral sphincter. All right, and that's muscles that are in the pubic, the pelvic angle. So we can see that a little bit better in lab. Sciatic nerve, remember there is nothing innervated specifically by the sciatic nerve. We see it in the posterior thigh, but what component of it is innervating muscles of the posterior thigh? The medial component, which is tibial nerve. So the medial aspect, the side closest, this side is going to be formed of tibial nerve fibers. This side would be formed of common fibular or peroneal nerve fibers. And in the posterior thigh, it's going to be the tibial nerve. There's one exception.
What was that last nerve on the last side?
Okay. So tibial nerve is going to do posterior thigh, so we're talking our hamstring muscles, our biceps femoris, our semimembranosus, and semitendinosus. There's one exception, and that is the common fibular nerve is going to do the short head of the biceps femoris. Otherwise, everything in posterior thigh is tibial nerve. Tibial nerve then goes on to do posterior leg. So we're talking gastrocnemius and soleus and our flexor flexor hallucis and flexor digitorum and tibialis posterior. All the way down the leg is going to be tibial nerve. And then as you can see here, the common fibular nerve passes laterally. Remember, it was the lateral component of our sciatic nerve. The common fibular nerve passes laterally and gives off two branches, superficial and deep. And we'll see those where they are in lab. In the muscle section, we just learned them with the muscles. but we can see them in the muscle models. So deep fibular is going to do anterior leg, that's your extensor muscle. Tibialis anterior, extensor hallucis longus, extensor digitorum. And superficial fibular does the two fibular brevis and fibular longus, or peroneal brevis and longus. We won't see the superficial fibular in lab actually in the lateral compartment. We will see it when it becomes superficial, really superficial, and innervate sensory the skin over the anterior leg. So you'll actually see it in the models as a nerve over extensor digitorum longus and tibialis anterior. At that point, it's not doing motor. It's only doing sensory, the anterior leg and the top of the foot. Interestingly, deep fibular is also sensory, but to just a small portion of the foot. The web space between your big toe and second toe. That tiny little piece of skin there is the only sensory area that deep fibular innervates. If you get a blister wearing your summer thongs or flip-flops for the first time with that piece of rubber between your big toe and second toe, that's the deep fibular nerve. Okay. Now let's look at, I want to go to the neuroembryology part here, and we'll come back to this in a moment. So before I talk about the sinuses, I want to talk about the ventricles. So I have this slide open here. Talking about neuroembryology really briefly. When we do talk about it, we're not going to go into all the different stages, but in the embryo, my youngest son and I had an argument. He was taking biology as a sophomore in high school, and for some of their projects, they had to do the mitosis model and the cell model and stuff like that, but they also have to come up with songs. And so his group of friends, he writes the lyrics. And they kind of set the bar when they wrote the song about the cell, and they did it to a dance video and filmed it and did Garage Band and all that. I don't know the software, but they got 150 points out of 100 for that particular production on the cell. And now they're doing stem cells, and they have to do one on embryo development. And so he was telling me what he was covering, and he talked about the embryo forming the blastula, forming the, and wait, you got it backwards, honey. The embryo doesn't come until after the blastula. And we have the embryonic plate. So small, that's not what my book says, Mom. I'm like, okay, show me your book. So then I do a whole lecture on embryonic development. And apparently there are other definitions of the embryo, because the embryo, the zygote, where the egg is first fertilized by the sperm, is considered to be an embryo because it's the first time you have the genetic material for a unique individual. Even though most of those tissues will go on to form non-embryonic tissues. And so you move along in the development, you have the blastula implant, and you have the inner cell mass, which is going to form the embryonic membrane. The rest of the ball of cells is forming the placenta. And then it says you have the embryonic tissue and the non-embryonic tissue. So I said, see, honey, here, this is what I'm talking about. The embryo is what's going to develop into the fetus, and the non-embryo is the other tissues. I know, Mom, but over here, so I learned to quit arguing with my kids when I'm the mom, not a teacher at that point. So I asked to see the actual words last night when he was done, and he said, well, it won't make any sense because you don't know the music. And I said, well, then sing it to the music. He goes, no, I don't want to sing it. Well, then let me read the words, or play the music for me. He goes, well, it's a song that you won't like because the words are bad. I said, well, so I've never seen it. I've yet to see it. Maybe I'll see it when it's done. But what we have after implantation and after the inner cell mass develops, we have an embryonic plate, which is, and the first read here, just getting you to a point where we can look at the development of the embryo in the neurotube. We have this oval disc, and a groove appears in it. And cells migrate through that groove. And we end up with 3 layers. We end up with 3 layers of tissues. And within that groove, we have, it closes over at the top. And we talked about this a little bit when we talked about the spinous, the lamina, the spinous processes of our vertebrate fusing. If they don't fuse, we have a condition known as spina bifida. Okay? So in the most severe form, the neurotube itself doesn't fuse, because you can see it starts to close kind of in the middle, and it moves towards the head and towards the tailbone as it closes, usually closing off first at the head region and last at the tail region. Spina bifida can occur at the base of the brain, but most commonly it occurs in the lumbar region. And in its most severe form, we have this appearing where we have the tubes, the spinal nerves forming just a tumbled mess, and they don't move down into the lower limbs. So the muscles are not innervated. Then we can go to the non-severe form, where the nerves migrate down into the lower limbs, but the bone doesn't fuse. So those people don't even know they have a form of spina bifida unless they see an X-ray. So you can see the limbs are thinner, the muscles are not developing because they're not of use. So this first fusion, creating the neural tube, is going to create the structure that we eventually will know as the central canal. And in the brain, the ventricles. So central canal and spinal cord, in the brain, the ventricles. And so our nerve cells, which are formed from that top layer of the embryonic plate, migrate down as well, and the cells around the neural tube are going to develop into the neurons. Either the gray matter of the spinal cord or the gray matter of the brain. So now I'm going to show some slides that show a progression of the changes, because our embryonic plate here is flat. Right? We don't have any abdominal cavity. It will fold longitudinally to create a visual cavity, the thoracic and abdominal cavities, and then it will fold to create the C-shaped form of the embryo and the fetus that we're more familiar with. So in this first image, you're seeing the fusion and creation of the neural tubes. This is within the early part of the 4th week after fertilization. All right? This is when, by gynecological terms, the woman is about 6 weeks pregnant. As we start the pregnancy date at the time of the last menstrual period, which is not exactly when, it's about 2 weeks prior to fertilization, typically, on a typical cycle. At the top is a longitudinal view of the developing embryo. So you can see the spinal cord and in the head region, they're about the same diameter. So this is a hollow-filled space, and then the brain tissue or spinal cord tissue is going to develop around that. You'll notice at that first top diagram, we have 3 regions of the developing brain. Within these 3 regions, we're going to see the spaces that we're going to call the ventricles, that we associate with each of those components. These 3 regions will eventually become 5, starting out from the side here. And getting very large, and the smaller portion staying in the center. So this is the development of the cerebral hemispheres, and that portion of the actual structure that we know as frontal lobe and temporal lobe occipital lobe, and so on, is known as the telencephalon. The medial portion is overgrown, and we can only see it if we cut the brain in half, is known as the diencephalon. So those two structures are going to develop from the prosencephalon. The mesencephalon, as I indicated, doesn't change. So that never develops into anything else except the midbrain. And in the back, our rhombencephalon also develops into two smaller ventricle spaces. Metencephalon and myelencephalon. So pons and cerebellum are actually going to develop from the metencephalon. Encephalon, if you haven't figured it out by now, refers to brain. Encephalitis is the inflammation of the brain. And medulla is myelencephalon. So those are our 5 embryonic vesicles. The central canal just gets smaller and smaller in the spinal cord. So we have telencephalon, diencephalon, mesencephalon, met, and myelencephalon. The yellow structures that you're seeing are cranial nerves growing out of the brainstem. We'll come back and talk about those after break. And you can see that we're starting to get a growth of the eye here. That's going to come out of our diencephalon. Down at the bottom, notice how large our telencephalon is getting. These are those swollen elephant ears I was talking about. They give us the cerebral hemisphere. Our diencephalon is giving rise to the eye here, and starting to become covered by the telencephalon. Notice the bending occurring between the metencephalon and the myelencephalon. The cerebral spinal fluid space in here, because of that bending, is going to become diamond-shaped. If you've ever taken a hose, like a garden hose, and you bend it, it doesn't maintain its nice, or even a straw, it doesn't maintain its nice round shape. It widens at the bend. So that provides the diamond-shaped change that's going to occur to the cerebral spinal fluid space associated between the pons and the medulla. This looks now the more erect position. So you can see that telencephalon is almost completely covered the diencephalon. The mesencephalon is still a distinct structure. And now the metencephalon is starting to see an additional rapid growth. And this is going to be the folds that become the cerebellum, that form the roof over our 4th ventricle, and eventually over part of the medulla as well. Now growth is very rapid, and it shows by increasing folds of the surface of our telencephalon, our cerebral hemisphere lobes. Now our diencephalon is covered up, our mesencephalon is covered up, and so dorsally all we can see is our cerebellum. Here you're seeing a little bit of the pons and the medulla. Now let's look internally at the spaces, because we have those cerebral-filled spinal fluid-filled spaces. And what, you guys remember the neuroglial cells that line the central canal and line our ventricle spaces? That work with the pia mater to make CSF? The only ones that didn't look like stars? Ependymal cells. All right, so these ependymal cells are going to start to secrete cerebral spinal fluid. And so the space, that neural tube canal, has gone under changes as well in the development of the brain. So I'm going to write them in right here. So the ventricular space of CSF that we associate with the telencephalon are 2 lateral ventricles. one in each hemisphere. It's gonna, and they'll go forward, they'll be pulled backwards, they'll be pulled around to the side as we see the growth of the frontal, occipital, and parietal lobes. The single face associated by the diencephalon is the third ventricle. Remember the mesencephalon was our least developed? It still looks like a central canal. Very long and slender, and that's known as the cerebral aqueduct. It's the area most often blocked and can cause increased pressure in the brain as the fluid that's supposed to circulate back to the cardiovascular system is blocked, and so the brain tissue has to swell. And then both the components of the pons and the medulla share the fourth ventricle. All right, so let's look at the image of that space. You have this table in the online lecture notes, and this central illustration along with the terms is what you will see on your lecture exam. All right, so I'll have that very small, about like that big, on the lecture exam, and with questions that say, from this information over here, the fourth ventricle is associated with which of these? The midbrain would be a component of which of the following? Or the hypothalamus would be a component of which of these? All right, so you'll have the structures and their order in the diagram, and then you need to be able to match. And again, as I talk about them in the next few lectures, I'll remind you this is part of embryonic mesencephalon, or this would have been a component of the diencephalon. So you'll keep hearing that from me. So here's just another view showing the changes and how we view them in the more adult version. And here's a full ventricular structure. We have a model of the ventricles in the lab. It looks just like this structure here. And what you have to keep reminding yourself is it's negative space. So it's as if we took the cerebrospinal fluid in the ventricles and replaced it with plastic. Poured plastic in there, let it set up, and then dissolve the brain tissue away. So the solid model is really the cast of a space. All right? And you have to keep reminding yourself that this hole right there in our model is where a solid structure would have been. Just like our solid structure is where a hole would have been. May I erase the material that's over on the whiteboard now? Because I want to kind of redraw this and go through it with you. Everybody okay? And all this material that I wrote on the board is in that previous table. All right, so I'm going to look at the lateral view on this side here and diagram that part. So our lateral ventricle is shaped like a C. If you take neuroanatomy, or even in this unit, you'll notice a lot of the structures of the brain are C-shaped. And that's because of its growth. So we have a rapid forward growth with the frontal lobe, a rapid posterior growth with the occipital lobe, and a rapid outward growth with the temporal lobe. And that's reflected because those three contain parts of our ventricular system, this hollow space into which we're secreting cerebrospinal fluid. So in the frontal lobe, we have this component of the lateral ventricle known as the anterior horn. It's pulled into the occipital lobe. So this would be in the occipital lobe. This is in the frontal lobe. and then out to the side. So this is not right under itself, okay, it's turning out to the side. So if this was the lateral ventricles, my fingers were the lateral ventricles, this would be temporal lobe, back here would be the occipital lobe. You'd see the pattern like this. So the lateral ventricles are close in the middle, they're kind of spread out in the front, spread out way to the side. They go out into the temporal lobe, and then come together in the back. And then this would be the inferior horn in the temporal lobe. And again, you can see that pattern from looking anterior posterior view right here. So you can see how it goes out to the side. Then there is a small opening or channel between each lateral horn coming towards the middle. So coming towards the middle like this. And this is known as the interventricular foramina or foramen. And it flows into a narrow third ventricle. And that's because it's for the lateral walls are formed by nuclei of our diencephalon known as the thalamus. It's like two tall skyscrapers that are about 20 feet apart, and that creates this narrow slit. In the brain, it's about 2 millimeters, all right? And so it has this kind of funny shape down here where the optic nerve and the pituitary gland are formed. And it has this two parts of the thalamic nuclei touch, so the fluid has to flow around it. So that's going to be our intrathalamic adhesion. And this is the third ventricle. So that's found in the diencephalon. The thalamus forms the lateral wall on either side, and the hypothalamus will form its floor. And then we have a narrow portion, not that long, but a narrow portion passing through the midbrain, known as the cerebral aqueduct. And that's really narrow. And then in the pons and medulla, we have our fourth ventricle. The peak at the top, so this out here would be wider, what I've drawn here. The peak at the top, just under the cerebellum, is an opening known as the median aperture. So this is how cerebrospinal fluid leaves. We'll look at this on Monday. And then out here are two openings to the side, so we have two lateral apertures. And the rest of this is going to go down into the central canal of the spinal cord. All right, so we'll add this to our dural sinuses on Monday. And in lab today, you can follow the flow pattern. So here would be the membrane that closes off the two lateral ventricles. Here would be our third ventricle, the cerebral aqueduct, and then our fourth ventricle. All right? Remember, our quiz today in lab is